Welcome to the Prospective Doctor podcast, brought to you by MedSchoolCoach. Each week we cover topics related to the pre-med journey to medical school and beyond, from the MCAT to completing your application and from starting medical school to choosing a specialty. Our podcast will provide essential information for anyone contemplating a career in medicine.
Hi everyone, it's Dr. Marinelli here, and today we have Dr. Mehta on the line. Hi, Dr. Mehta.
Hi, how are you?
Good, thanks. Thanks for joining us. So today we wanted to continue our medical case series that we had started about a month ago, and Dr. Mehta has a pretty cool interventional radiology case that he's come across, which is not necessarily confined to the field of interventional radiology. And I think I'll let him tell you more about that, but more of a case that teaches us a little bit about medicine, its implications, and how we treat patients throughout the years. Dr. Mehta, do you want to go ahead and start by telling us a little bit about this specific case?
Yeah, sure. So actually, this was a case that I came across as an intern. And so this was before I knew anything about interventional radiology, knew anything about catheters and wires and stents, and honestly, the treatment of what the case is about. And so really, this is applicable more for general medicine than interventional radiology. It's interesting because now that I look back at it years later and I treat patients with this same condition with the stenting that I can do, it becomes even a more interesting case for me. But as you mentioned, I think the real implications of this case are kind of thinking about medical treatment and what we do and how that affects us later on, or how we oftentimes don't know how that affects us later on. So this was a case that I came across when I was an intern at Memorial Sloan Kettering. And for the listeners who may not know, Memorial Sloan Kettering in New York City is a really big cancer hospital, probably one of the two biggest in the country, and really sees a lot of very advanced cancer patients with incredible care that they provide. And I was an intern at that hospital for a year, and I came across this woman, and she basically had come in with dyspnea and exertion, which is shortness of breath, essentially. And for those of you guys who are going into medicine or going into med school, you'll figure out that dyspnea and exertion is, one of the most common symptoms that any patient can present with. And there's literally, a list of 100 different things that could be, maybe even more than that at the end of the day. But, starting with, hey, this patient came in with shortness of breath and ending with where we're going to end, I think is a really interesting journey, particularly in her case.
Awesome. So what can you tell us a little bit about your kind of evaluation of the patient and where things went?
Yeah. So, she was a 69-year-old female, and she had come in with basically 3 weeks of this progressive dyspnea and exertion, which again, 3 weeks of progressive shortness of breath. So she was getting more and more short of breath over the course of 3 weeks, prompting her finally to seek care in our emergency department. When I first saw her respiratory rate was in the high 20s. And so for those of you guys that don't know, sort of a normal respiratory rate is maybe around 10 to 12 breaths per minute. And so obviously, when you're short of breath, you breathe a lot more and you try to get a lot more oxygen. And the first thing you notice about her was that she was breathing very quickly because she was trying to get more oxygen. She had already been put on a oxygen mask supplementation. So she was stable in the sense that she was satting okay. So satting is a quick word that we use for, hey, how much oxygen is really getting to her tissues. And so her oxygen saturation was 97% when she was on the 3 or 4 liters of high flow oxygen. So she was doing okay. She wasn't going to, she didn't need an intubation or anything at that minute, but she was clearly quite sick. And so I started my history and physical. And again, for those of you guys who are going into med school, you'll learn that the history and physical is the very first thing you do with a patient, right? You kind of understand why they're there and you get their medical history. And her medical history ends up being really interesting. She was diagnosed with Hodgkin's lymphoma when she was 17 years old. And so remember, she's about 70 years old now. So 50 plus years ago, she was diagnosed with Hodgkin's lymphoma, which ended up, it first was diagnosed in her because she basically had a big lymph node in the right side of her neck. And she basically at that time was treated with a dissection. Now, she was from Cuba. And so, some of the medical care was probably different I'm trying to think. I mean, this was probably 50 years ago in Cuba. So you're talking about, the 1960s, 1970s. Where she was initially treated with a lymph node dissection and then unfortunately developed recurrent disease a few years after that. And that recurrent disease was basically in her mediastinum. And at that point, she got radiation. And so radiation has been sort of a mainstay of treatment for lymphoma for a while. And radiation involves essentially shooting X-rays and proton beams and high energy, let's just think of high energy molecules at the patient in order to disrupt the tissue, right? In order to kill the tissue. Mm-hmm. And so she basically underwent this radiation at the age of 20. And, she did great. I mean, that cured her in a lot of ways. Like, she did not have a recurrence of her lymphoma at all since that time. And so, I mean, it was really remarkable that she was able to be cured in the 1950s, 1960s in Cuba with radiation, and she was cured of cancer, which was great. But what has ended up happening to her is that, unfortunately, over time, she developed all kinds of complications based on her radiation therapy. So at around her 40s, she developed a bone sarcoma in her right clavicle, right in her radiation zone. Then in her 50s, she developed bilateral breast cancer, for which she got mastectomies and chemotherapy. Then in her 60s, she basically developed right subclavian artery stenosis. So she basically wasn't getting enough blood flow to her right arm at that point. And at that point, somebody had tried to stent her. It wasn't successful. So they ended up doing a bypass for her subclavian artery to essentially get more blood to her right arm. And with that bypass, she was also placed on anticoagulation, which basically thins out your blood to keep the blood moving at a faster pace through the body. Yeah. And then a couple of years after that, she developed pericardial constriction. So basically, she had fibrosis and she had issues with her heart and the surrounding of her heart being able to beat because of the radiation therapy. So it was constricted. And then she also had, at that point, severe tricuspid regurgitation. She needed a tricuspid valve replacement. She needed a pericardiectomy, which basically removing that pericardial tissue. And that was all the stuff that had happened to her up until this point, where she kind of had presented again for shortness of breath, right? So, I mean, I already named about 5 or 6 complications of radiation, unfortunately, that she developed over the course of her 30s, 40s, 50s, and 60s before I even saw her, all because of the radiation that she got when she was in her 20s.
Wow, that's crazy. So I guess, you're taking all this into account as an intern. This is a huge case, probably a ton of medical records to sift through.
Oh, yeah. I laugh because I actually distinctly remember that she was treated at another hospital, at Mayo Clinic, actually, for a while. She had care all over the place, but she was a very meticulous patient, and she brought with her all her medical records. And it was literally binders full of medical records, because unfortunately in our medical system, we just don't have a good way of communicating between hospital to hospital. And as an intern,
that's your
guess
job.
Whose job it is to sit there and figure out what this patient's history was. So I distinctly remember going through note after note after note, trying to put all this together and figure out what was going on with her in the past, while I'm also trying to figure out how to treat her in this acute setting.
Right. So, I mean, that's kind of my next question is, how did you do that?
I distinctly remember sitting there and going through each and every record of hers and kind of trying to piece together as much as I could. And, a lot of this piecing together came over the course of a few days, and it's impossible to do it all, the minute you're kind of confronted with a patient. But it was a lot of work to just read through and understand. And even at that time, it didn't, because what happens in medical records is that each and every physician kind of deals with each and every issue that they're presented with.
Right.
It wasn't very clear that all of these were complications of her radiation until you sort of take a step back and realize, oh, you know what? She had radiation in her 20s. She had a right-sided lymph node. That's why she had radiation on the right side. That's why she developed this. Then she had mediastinal, or sort of in the middle of her thorax, radiation as well for her recurrent disease. That's why she developed the breast cancer. So it's almost like a medical mystery, right? You come back and you put it all together and you realize what's going on. When you're just confronted with a small problem and, you say that, oh, she developed bilateral breast cancer. Well, that happens in a lot of people. Right. That doesn't mean that they had radiation. But then when you say, well, she developed bilateral breast cancer and she developed a right-sided sarcoma and she developed a right-sided subclavian artery stenosis, and she developed pericardial constriction. All that stuff. Now you put it all together and you're like, oh, you know what? This is all because of the radiation that she received.
Wow. So, I guess my question too, and I think there's, so much here as far as she's now in her 60s, she's dealing with a new problem. She's had all this other stuff that's gone on as a result of, a disease that she had when she was really young. How do you've named several reasons why she could be having shortness of breath on exertion right now. So how did you even kind of go about evaluating her and, kind of getting to the root of her issue now?
Yeah. So, I think like anything else in medicine, when you're presented with a symptom, sometimes the nice thing about medicine is that the checklist you have to go through diagnostically to understand what's going on, right? And so for her, that involved a BNP level, which is basically a level that measures if you're in heart failure. It involved normal labs to understand what was going on. It involved a chest x-ray to see if she had a pneumonia or something like that could be causing her shortness of breath. It involved an EKG because a lot of times heart issues can cause shortness of breath. It even involved, in her case, an echo because, again, the heart issues, and let's say your heart's not pumping enough blood, that could cause shortness of breath, right? So we call that sort of heart failure. And you look at something called the ejection fraction, which is how much blood is being pumped out of the heart on every beat. So you kind of go through all these different steps. You actually, I remember she even had like pulmonary function tests from a year before, because it could be when somebody comes in with shortness of breath, it can be their heart, it can be their lungs, it can be an infection, it can be all these different things that potentially can cause the shortness of breath. So you kind of got to go through the checklist and see all those. And so we basically started that checklist, right? So we get the EKG, we get the echo, we get the chest x-ray. And initially what we kind of ascertained was, oh, you know what, it looks like she may have a pneumonia. And that would certainly explain some of her shortness of breath, right? A pneumonia certainly can cause shortness of breath. But then we started treating her with antibiotics and she wasn't getting any better over the course of a couple of days. And so now we have to dig a little further. What else can be causing this? And it's at that point where we basically ended up getting a CT scan. And after she was basically, finished her course of antibiotics, didn't have any improvement, then we finally got a CT scan. And actually, that brings up a point, which is like, hey, why don't you just get a CT scan ahead of time, which a lot of people would have done. But keep in mind, this is a patient who already had been exposed to a tremendous amount of radiation in her lifetime and had all kinds of complications from the radiation. So you want to kind of be a little bit selective in who you sort of exposed to more radiation. Obviously, if you need to expose them, you can, because it provides a good understanding of what's going on. But we didn't want to do that off the bat in her for, I can't remember the exact timeline, but it was a couple of days where we said, okay, let's hold off. We don't think she has a DVT, which would be a reason to get a PE CT scan or a CT scan that shows the pulmonary arteries. So we didn't think she had that. We had some additional testing that didn't show any clots, and her, what's called an INR. And basically that's how thin her blood was. Her blood was thin enough. Like it was in a good portion where we thought, this probably isn't a pulmonary embolism. So we didn't get a CT scan off the bat.
Right.
So eventually we get the CT scan. And then, at that point, what we basically see is we see that she has all kinds of venous collaterals on her right side. And now you start putting this together and you kind of look at her face and realize that, if you start sort of targeting the question a little bit more, she says, my arm is more swollen than it was before. And my face feels very swollen comparatively to what it was before. All signs of something that we call SVC syndrome. Mm-hmm. And that was kind of confirmed on the CT scan, where you saw that her SVC, her superior vena cava, was basically non-existent or severely narrowed, and her blood was actually flowing through all these other veins to get back to her heart.
Wow. So let's kind of wrap it up here. You get this super complicated patient, has a huge history. You spend hours going through her medical records. You try something to take care of her. It's not working. You do another test and then kind of figure out, what may be causing her shortness of breath. And I'm assuming you guys took care of that issue. Where do you go from here? What do you take away from a case like this?
Yeah. So, my sense is that the real things to take away from this case are not necessarily the diagnosis or even how we made it. But to me, it's the consequences of medical treatment that we just don't know about. When she was getting this radiation in the 50s or 60s in Cuba, and I don't think they probably didn't even think that she was going to live to the age of 70. They probably said, hey, we got to take care of this patient right now. She has radiation. We think we can save her from this radiation. And they did, Hodgkin's lymphoma, otherwise she would have died from that probably. But she was saved and she lived this long life. Obviously she had a lot of medical issues, unfortunately, but she did live, and was disease free from a lymphoma standpoint. But to me, it's sort of like an incredible story of, hey, what do we do in medicine today that we just don't know what the consequences are tomorrow, right? And that's despite all the testing and everything else that we do. There's so much that we can probably look back upon 20, 30 years ago that we today as physicians say, that was crazy. Why would they do something like that? Or that was dangerous, or, who would treat somebody like that today? But I think sometimes physicians are naive and think that, whatever I do today is the right way. And I certainly, in the patients that I treat and in my practice, I know that somebody is going to look back 30 years from now and say, what was he thinking? What was he doing? Like that was terrible. Why would you scan a patient head to toe and expose them to radiation? That's crazy. I could see somebody saying that. Or, why would you put a stent in a young woman, who has May-Thurner disease, which is something that I do because, they might have compression of a vein or something. I could see some people, 30 years from now looking back and say, we would never do that today. That's crazy. We have all these other ways of treating these patients, right? And I think that's true of every single field in medicine, of every single thing that we do, that we try to do what's best today, but we often don't know what the consequences are 5, 10, 15, 20, and certainly not 30, 40, 50 years from now.
Mm-hmm. Yeah. And, that makes me think of a little bit of, there can be some public distrust in medicine. I think sometimes when, you hear on the news that a new study shows that, drug X was used for years and years, but now shows that it's dangerous. I think that creates a little bit of, sometimes uncertainty within medicine, distrust from the public that maybe they just don't understand that things are constantly being tested and new treatments are coming out. And like you said, things that we're doing now maybe become obsolete or even become something that we find out that's harmful. Can you talk to maybe, potential medical students or people that are currently in medical school? How are you going to deal with that?
Yeah, I think there's distrust of medicine, and then there's also, there's distrust of medicine sometimes because exactly what you said, hey, sometimes what happens is that we don't have all the information in front of us, right? As great as the clinical trials we try are to do, they're not always as thorough as we want it to be. Or sometimes we don't have clinical trials because we need to rush medicines or treatments out because patients are dying, and you need to do something for them. And you can't go through a robust randomized control trial and wait 30 years and see what the implications are and then decide if you're going to use that drug or not, right? You just can't do that in a patient who needs treatment. And so I think, in my opinion, what I think that med students and physicians in general just need to they need to stay humble, which is to realize that we don't have all the answers. And, the things that we do today are to the best of our knowledge and our capabilities of today. But that doesn't mean that, 20, 30 years from now, people aren't going to look back and say that was dumb or that we shouldn't have done that. And I try to explain that to my patients all the time. I'm doing some relatively cutting edge and new techniques and new procedures, oftentimes in my clinical practice, that have only been done, a few hundred times, if not less than that sometimes, or have only been around for a couple of years. And, the patients come and say, what's going to happen to me in 10 years? And I always give them the honest answer, which is, I have no idea. Here's my best guess of what I think is going to happen based on what I've done in the past or what similar procedures I've produced in the past. But I can't really give you 100% accurate answer as to if you're, let's say your BPH, your prosthetic hypertrophy, which is something I treat, is going to come back in 10, 15 years because really we have no idea. And I think that's at least the way I approach it. Mm-hmm. I've seen physicians approach it differently, which is to say, some physicians will say, this will cure you and you're good to go. And I think that's sometimes where maybe the distrust comes in, or or the frustration comes in. I mean, certainly from a patient experience standpoint, I would be frustrated if somebody said, you're good to go. Don't worry about this. See you later. You never have to worry about it. And then, 15 years later, you find out that you should have worried about it or you should have followed up on it. I'll give you just another example. In my practice, I take out a lot of IVC filters or inferior vena cava filters that were placed 10, 15 years ago. And basically at that time when we were replacing them 10, 15 years ago, the prevailing theory was, hey, put them in. Nobody's got to worry about them. They're permanent. They'll be fine. Nobody's going to get injured from them. They're okay. They're going to protect people. And we've actually realized over time that actually that's not true. They actually do harm people. And so now we make this big push to get it out. And so I see patients who come and say, the doctor who put this in told me I never had to worry about it, but now I have back pain or I have this or that, or my legs have clotted off. And then we have to deal with it, right? So it's just, I think, setting expectations and, again, understanding as a physician that we're very human. We don't have the answers always by any means whatsoever.
Yeah. And I think even another aspect, another layer to that too, is even procedures that maybe you do commonly or you're treating patients with a very common medication, not everybody responds the same. I mean, for this patient that we've discussed, not everybody that received radiation in the 50s or 60s from Cuba probably developed the same complications. She's definitely a case study where for some reason her body was more vulnerable to the radiation and developed all these subsequent complications. So even as certain as you can be with a certain treatment or intervention, every patient's going to respond differently. So there's still that variable, which is going to always be there. And I think, you've probably seen that a million times. Something that you do very commonly, maybe a patient has an outcome that you just didn't expect because it was just dependent on how that patient responded.
Yeah, absolutely. I think we're on the cusp of understanding a whole lot more in medicine just because of, personalized medicine and genomics and all those kind of things. But at this point, we don't know. We just don't know everything.
Yeah. And I think that's just so interesting. The other thing that really, I think this case kind of brings home is that how medicine is so much of it, probably, 99% of it is all a weighing of risk and benefits. Radiation therapy was probably pretty relatively new, I would assume, when she got that lymphoma treated when she was in her 20s. So they probably didn't know all of the outcomes or what to expect. But certainly, nowadays we have enough follow-up from people that do or have had radiation. We know that its effects can be detrimental, and we still do radiation for a lot of cancers. So it's still a treatment that we use, and we try to mitigate those risks associated with it by using, lower doses and things like that. But I think it's a good reminder that there's always just a weighing of a risk and benefit for pretty much everything you do, even if it's a blood pressure medication versus, removing an IVC filter and, what that potentially could cause later on down the line and the risk of surgery and things like that. It's always just this kind of laying out, what this is going to do, potentially good for the patient and how it can potentially harm them.
Absolutely. No, it's always, everything is risks and benefits, as you mentioned. I wish we knew all the answers, but we just don't at the end of the day. Yeah. I just want to plug one thing. If listeners kind of are intrigued by some of this, and I hope you are as sort of a pre-med student or even a med student, there's a great book that I recently read called The Emperor of All Maladies. Yes. And it's by this guy, Siddharth Mukherjee, and he's an oncologist, and he goes through the history of sort of cancer, how it was treated from like the Greek days to the 50s to the 70s to today. And it's really what we've just talked about, but in a much more eloquent way, because he's a great writer, certainly a whole lot better than I am, and has really gone through all this stuff. And it's fascinating because you kind of look back and you see, wow, what was done in the 80s, just the 80s or the 90s or even the 2000s that we look back in today or like, well, that was the wrong thing to do, or that really didn't help anybody. That just harmed them. We thought it might help them, but it really just harmed them. And it kind of goes through the ways that some of these treatments came to be and their history behind them. I think it's really a awesome book, and I would highly recommend it to anybody who's in this process going through, because I think it just, I mean, it just gives you a lot of talking points for interviews, but more than that, it just really is interesting.
Yeah, I agree. I read that book as well. It's very fascinating and a great analysis of kind of like you said, the whole history of cancer. And I think even sometimes we think of cancer as like such a modern disease, but I mean, there was cancer, like you said, in ancient times, and it was so interesting to see how they approached it versus how we approach it and the similarities and differences even now. So yeah, great book. Well, thank you for sharing this awesome case. I hope it gives the listeners out there kind of something to think about and, just kind of keep in mind as they go through and practice medicine. Any last thoughts or things you wanted to point out, Dr. Mehta, before we end?
No, I mean, I think we learn from every single patient we treat, right? I mean, this one particular patient, I learned so much from her, right? I learned so much just from her medical history. And I took what I learned from there with me into my own practice years and years later. It happens to be like this SVC syndrome happens to be something that I treat on a fairly regular basis now. But no matter what I went into, I would have really taken her story and the understanding of what she went through with me, and I think it's really important that we always remember, every single patient we treat can teach us something and make us understand something. I mean, this is somebody who was cured of lymphoma. Like, how could you do better than that? Well, yeah, it was awesome that she was cured of lymphoma, but she spent probably half her adult life, if not more than that, bouncing between hospital and hospital because of all the medical issues she's had. And, I never asked her this question, and it would be fascinating, obviously, to ask her this question. And I don't think it would have been appropriate for me to ask her this, but just to think like, hey, was it worth it? Right? I mean, was it worth it? And I'm sure she would have said, yeah, listen, I got an extra 50 years. I got to see my kids grow up, whatever it might be. But maybe there are some patients who would have said, you know what? Everything I went through after that wasn't worth it. Like maybe I wouldn't have been treated if I could go back in time and understand everything that was going to happen to me. Maybe I actually would forego the treatment and say, you know what? I'm okay. And I mean, I don't think that would have been the case in her case. She was young, but there are patients today who are in their 70s or 80s who we treat with chemotherapy or big surgeries or whatever it might be. And they have complications down the line. And maybe, those patients are somebody we can ask, hey, listen, these are the things you may face because we're going to do this. These are the things you may face in the next weeks, months, or years of your life. Do you want to do that? Right? Or are you saying, listen, I'm happy with where I am.
Yeah, absolutely. Well, thank you so much, Dr. Mehta, as always, for joining us. I appreciate it.
Not a problem.
Thanks, everyone, for listening.
Our mission is to inspire, encourage, and inform students as you journey through a rigorous and intricate process of achieving your dreams in medicine. Visit us at prospectivedoctor.com and MedSchoolCoach.com for more essential resources in your medical school journey and beyond.